speaker is Dr. Parimal Gharia. He's a very good friend of mine, and he's also stationed in Surat right now. And he is expert endourologist with vast experience of all endourological surgery with special interest in endoluminal endourology. Dr. Parimal Gharia is amongst the pioneer of use of suction in RIRS. He developed his own technique of intrascope suction, which is called MIST, which is manual intrascope suction technique. Dr. Parimal is one of the very early users of fans and demonstrated RIRS fans at EuroLithocon in 2024. So I would like to invite Dr. Parimal for his talk on fans in RIRS. Parimal, you're on.
Thank you, Saturday School of Urology and Dr. Madhusudan Agrawal, sir, for inviting me for this presentation. Topic is fans in RIRS, a new kid in a block. So what's a fans in RIRS? Fans in an acronym used for a flexible and navigable suction ureteral access seat. There were many different names were used for a suction ureteral access seat. That was a flexible vacuum assisted ureteral access seat, or a tip bendable access seat, or a bendable ureteral access seat. But ultimately, Dr. Gohar et al. Described this as a flexible and navigable ureteral access seat, and has now been universally accepted to be called as an RIRS fans. So disclaimer, there is no conflict of interest. So what are the problems of existing system of RIRS? The poor vision, a high intrarenal pressure and associated with a urosepsis and subcapsular or perinephric collections, high intrarenal temperature, and the residual calculi and associated with these are the multiple procedures. So vision, intrarenal pressure, and a temperature all were dependent on the inflow and outflow. When there is outflow and inflow is matching, everything is under control. When there is a mismatch, there is a rise of intrarenal pressure, decrease the vision, and increase the temperature. The solution was only to increase the outflow. So various suction techniques were described to increase the outflow and decrease the pressure. The techniques were applied for the suction through the scope and the suction outside the scope. The suction through the scope was with or without devices, that is direct in scope suction or manual intrascope suction, or whether other modifications. And now the suction integrated scopes are available, whereas the suction is applied to the scope inbuilt. Others are the suction outside the scopes. Suction through the flexible scope has an advantage of universality. When there you can do an RIRS, you can do a suction through the scope, but it has come with limitations. It was always an intermittent because same channel was used, and dust can be aspirated, and the channel clogging was an issue. So a suction and ureteral access seat was invented. That was a non-bendable seat. A Y junction of suction was added at the end of the ureteral access seat, and now the concept was that the suction will have a continuous flow iglesias-like system where a fluid will go from the scope and it will come out from the ureteral access seat, but that is actively sucked up. So there is a good flow, and this Y junction was attached to a stone collecting bottle, and ultimately this stone collecting bottle was attached to a suction, which can be any suction that is available in your OR. So with all this, what we achieved is improved vision, decrease intrarenal pressure and temperature, and decrease in operative time. But still the balance was heavily in favor of PCNL because we do not have any on-table stone clearance with this system. Whenever we do a primary RIRS, we leave a lot of fragments which will require time clearance with the time only. And there was an uncertainty about the stone clearance. After 2, 3 weeks, 4 weeks, whenever do rescanning, you will find some stones, and then you are in dilemma what to do. So there were some unmet goals, and these goals were only achieved when we crossed the Lakshman Rekha of UPJ and advanced the acral ureteral access seat into PC system. For that access seat has to be non-traumatic, and it should be bendable. So it can all calyces, it can be bent to all calyces, and the suction can be applied where the ureteral laser lithotripsy has been done. So for that, a flexible and navigable suction ureteral access seat was achieved, where the distal 10 centimeter is a flexometallic tube, and it can be bent by the use of the scope. Here the seat is not bendable on itself. It is the scope which bends the seat. And this sheath has a tip that is non-traumatic. Whenever it touches the mucosa, it does not damages the callicial mucosa or uretropelvic junctions. Now, once we have introduced the ureteral access sheath across the UPJ into pelvic callaceous system, there are how the stone are removed. The stone removal can be achieved by the two mechanisms. The first mechanism is a suction of the dust between a inner side of the ureteral access sheath and outer side of the scope. So it is just like a continuous iglesias system where you do a dusting and the stone is actively sucked down, but now not in the ureter, in the pelvic callaceous system across the UPJ. Second thing was what observed was the same principle where what we were discussing about the PCNR, that the vacuum cleaner effect is present. There is a low pressure system just in front of the scope, which can attract the stone at that negative pressure system. And this negative pressure system can remove the stone at the end also. Now we add a suction into this effect will get exaggerated and you can remove the stone. So what we achieved is we can remove the small fragments or a larger fragments from the pelvic callaceous system directly by applying suction through the ureteral sheath. So now you can see that it's imitating the stone removal from the pelvic callaceous system. So what we achieved is the small advancement of this and adding an extra flexometallic part has a giant leap in the RIRS, because what we achieved was previously was not achieved. Now we can remove the fragments. We can do a dusting, continuous dusting at the most of the part of the RIRS, and when there are the fragments remaining, when remove the suction at the end of the procedures. And this was conceptualized by Dr. Gohar, and the first presentation about this sheath was in Eurotech by Dr. Gohar, and then the first report of came from the Chen et al. And then a comparison between a 10-12 and 11-13 flange sheath was achieved by Dr. Gohar, and they said that the suction effect is better in a 10-12 sheath in effect due to 11-13, because the vacuum cleaner effect is exaggerated by suction, better in a 10-12 sheath. So the smaller the sheath, better is the suction. And now the latest paper, the August 2024 paper, shows that the stone-free rate immediately or at post-op day 1, stone-free rate at 3 months, post-operative fever, and reduced use of the stone bucket, all can be achieved by using a fan sheath. So now the concept is we are reviewing the results. So what can be the indication? The standard indications for fans is a pre-stented patients, because we are crossing the ureter, we are crossing the UPJ. So first indication is always a pre-stented patients. And second thing is, most of the people are very fond of doing a primary RIRS. So what we left is, when we do a check RIRS at 3 weeks, 4 weeks, we found multiple small fragments in the PC system, which are not basketable. We are not removable. It is very tedious job to clear this system. In these cases, already patient is stented after first primary RIRS, and you can do check RIRS and remove all the fragments. Now we all know the story of Indian ureter, that Indian ureter are small, and we are fond of doing primary RIRS. But what happens is, around about 10 to 15% patients, we do not have access to pelvic callaceous system or the renal stone when doing a primary RIRS. In these patients, we put a stent. Then after 15 days, we do a second stage or a proper RIRS, and we leave multiple fragments into pelvic callaceous system. So we again need to put a stent, and then stent is removed at the third stage. So ultimately, 5 to 10% patient will have a 3 stages: stenting, proper RIRS, and digestate removal or check RIRS. Now with the fan sheath, the on-table stone clearance is achieved. And we have seen it. We have seen multiple videos by Dr. Chandramohan sir also, that on-table stone clearance is achieved. So in the patients who are pre-stented, and you are 100% sure that you have removed all the stones, almost 70% of patients, you can do a second stage without a tube, without even a DJ stent. So now when a tubeless RIRS is possible, we can do a liberal use of pre-stenting. We can do a first stage pre-stenting, do a surgery at the second stage, remove all the fragments, and we may not put the stent. So we are benefited in these cases, that the story is reversed, that a primary, if we do a RIRS in a properly prepared ureter. Even a primary RIRS is possible in under almost 30% cases, that primary fan sheath can go across the good ureter, and good UPJ and do a primary RIRS with the fans also. Bilateral surgeries are possible because the surgical time has decreased. So it is possible to do bilateral RIRS with this. And there are some extended indications. What are they? CKD. We are always worried about the removal of the fragments or the stone clearance in CKD. But with these fans, we can remove the stone actively and we can use that. Hydronephrotic kidney had a problem of stone fragment retrieval, and that can be taken care of by fans. Small kidneys, always there are chances of rupture of kidney, but with the fans, there is a negative pressure and you can do RIRS. Kidneys with the multiple secondary stones, we were avoiding RIRS in this patient because it is very tedious to remove 100 secondary stones. But with fans, that is possible. Metric stones is also can be done with the RIRS, but still we have a concerns. The concerns are scope maneuverability. Only 85% or a maximum 87% calluses can be reached by these calluses. Some calluses are not reachable by bends. Whenever we are using a reusable scopes, we are always worried about the scope durability. And secondly, we are crossing the fan seat across the pelvic enhancer system. There is a loss of secondary deflection. So whenever the calluses which require secondary deflection to reach, this cannot be done by this. And a longer seat outside. And secondly, the ureteral seat, there was always a debate about use of seat or without seat. Many people are fond of doing an RIRS without seat, and fans is not for them. Secondly, whenever you do have active flexion at UPJ, you are putting a strain at the UPJ, and we need to be taken care of this. And if not taken care of, you may injure the uretropelvic junction or upper ureter by seat. So what has changed? The change is there should be no debate about lasers. Whatever laser you have, either a high power or low power, TFL or holmium, you do not require to give it a base dusting. You fragment it, remove it. So hence the laser is over. Second thing is overhyped demand of extraordinary dusting is not required. So I think that just like robotic surgery, this will change the robotic surgery has changed the laparoscopy. This will change the RIRS. More and more people will adopt to RIRS by fans system, fans seat, and there is potential to democratize RIRS. And the recent advances is 9 French ureteral access seat, 6.3 flexible ureteral scope, pressure control system. There are pressure sensors at the tip of the ureteral access seat. You can control the pressure, what is the suction pressure or negative pressure applied to the system. And the steerable, you can change the direction of the ureteral access seat with the flip rather than actively deflating with the scope. So I think that RIRS fans is a game changer and is here to stay. Thank you.
There is a question from Dr. Anil Varshne. Anil Varshne is a master himself in endourology, and his question is to Dr. Parimal.
Yes, sir.
What if you are not able to? What if you are not able to put the fans?
The son is here, but he says that
if I could not put a fan seat, I would rather I would proceed with the standard RIRS, like putting a standard ureteral access seat below the pelvic junction of ureter, or may do a seatless RIRS also if the ureter is good. But if ureter is tight, just put a stand and come out. Better to fight on another day. After 15 days, it's my routine protocol.
So, do you find putting the fans sheath in lower calyx more challenging than upper and middle calyx?
It has been challenging. The previous generations of ureteral access seat which was available, the access seat flexibility is improving over a period of time. The latest one is around about what it say that it's around about 30% better in lower calyx than the previous generation was. So its quality is gradually improving. So the lower calyx accessibility is increasing day by day.
Okay. So without any conflict of interest, which of the access sheets, fans access sheets, have you found to be the best in your hand?
Two companies which I am using. One is from IGO from China and from the Esther in India.
Esther in India, you find good?
Yeah, it's good, sir.
So great. Thank you so much. Thank you. Another question from Dr. Mahesh Adhikari to you, Parimal. Opinion about stone clearance in hydronephrotic kidney in RIRS with fans.
Previously, we were very afraid of doing an RIRS in hydronephrotic kidneys, but with the fans, we can do a RIRS in hydronephrotic kidneys, provided we do not have very large kidneys, because with a very large kidneys, the curvature of the ureteral access sheath or curvature of the ureteral strip does not allow it to go to all galaxies. Though we found it is very easy to do in hydronephrotic kidney, but it's difficult to do RIRS in hydronephrotic kidney compared to a PCNL. So if only when the stone can be in a good favorable location, hydronephrotic kidneys are good. So in that case, if with a pelvic stone, we'd like to put it into the upper calyx and do an RIRS at that place.
Okay. So if it's a large hydronephrotic kidney with a large stone, you would rather go for a mini perk as compared to a RIRS.
Standard indications of PCNL stays standard.
Right.
Yeah.
Thank you so much.
RIRS fence does not compete at that place.
Yeah, and I fully agree with you that now with availability of fans, there could be a shift from mini perk to RIRS in at least many of these patients. So the challenge to PCNL is with RIRS is stronger now.
Yes.
Another question from Dr. Anil Varshney to Parimal. Share your experience in ectopic pelvic kidney and horseshoe kidney.
Horseshoe kidney, I have done 3 cases of horseshoe kidney, and I was able to reach into the almost all calyces except the middle one calyces, where I need to use a direct scope suction with the syringe by dusting the method, or I can transfer the stone. Ectopic kidneys, if it is in a not a cross-use ectopia, it can be done easily. But the cross-use ectopias, I find it even a simple RIRS navigating to the upper ureter and then the pelvic access system is difficult. And I think that the RIRS fence will be difficult in these cases. In these cases, manual intrascope suction or this is a better option.
In the pelvic kidney, I think the greatest challenge is in the pelvic kidney.
Pelvic kidney can be achieved. Dr. Chandramohan sir yesterday only shared the video of a ectopic kidney, where there is a ureter is very short and straight, and we can do an RIRS fence in this case because it's a short ureter. But only problem is the largest length of the ureteral access that is remaining outside the body. It is very difficult to handle because that is not as flexible as the other seats. So long segment outside the body is difficult to handle with the ureteroscope in situ.
Chandramohan, would you like to comment on that?
Yes, sir. I personally feel that the handling of the flexible sheath outside is very difficult. In these cases also, I feel that we have to stent and PUJ should be respected. And the access sheath should not be bent into the lower calyces. It will be an acute angle. So powder it, and better to suck the powder than the fragments repeatedly, because PUJ is slightly abnormal anatomy, high riding. So
Correct.
my personal feeling is that the length of the access sheath, now Clearpetra has come with 30 centimeter length. Those type of access sheaths are better than the regular access sheath of 50 centimeter. It will be too much outside.
Correct. Thank you. There is a question from Dr. Srikanth. Dr. Srikanth Radbe from Mumbai, and Dr. Neeraj and Dr. Abhishek Shah asking about the reasons for undilated ureter even after stenting. So, Dr. Parimal, Dr. Chandramohan, have you faced a situation where even after stenting?
Yes, sir. These are most dangerous situations for RIRS. That means in 5 to 10% the elasticity of the ureter, inflammation, whatever may be the reason, they will be rigid pipe-like things. So if you attempt just because taking for granted the post-stent and directly insert, it is not good. Better to do 6 by 7.5 ureteroscopy in all cases. If it is not going easily, switch over to PCNL. No attempting, especially fan sheath, because they are all 10 French as of now. So my feeling is that it can happen. It can happen.
Okay. Parimal, any comments?
Sir, as Chandramohan sir said that there are the ureters which did not dilate, specifically with some abnormalities or radiations and everything. That in that cases we have to sort to a if the upper ureter stent, then integrated flexible ureteroscopy or a standard PCNL or a mini plug will do the job. We have to explain to the patient that these are the rare scenarios, but it can happen to anybody at any point of time.
Okay.